Chief Operating Officer since 2018. She has also served as Executive Director of Strategic Planning and Operational Development at West Valley Medical Center in Caldwell, Idaho. And prior to joining West Valley, she served as Senior Decision Support Analyst with the West Florida Division of HCA. With over 20 years of healthcare and executive experience, her many areas of expertise include patient and employee safety, hospital culture, growth and engagement. She has a Bachelor of Science degree in Business Administration from Wingate and a Master's of Healthcare Administration from the University of North Carolina. She and her husband enjoy exploring Alaska with their 3 children. Ross Newcomb came to Alaska in 1967 with his family as a child in the military, graduated high school, joined the military, served there, went to college first. So he did his undergraduate in animal science at the University of New Hampshire, and then a master's degree in business administration from Webster University in St. Louis. He spent over 20 years in the military, a highly decorated officer, and then he has worked both in healthcare and other industries for 35 years, doing programming, planning, budgeting, executive and various execution of DoD, state and nonprofit agencies, and has served as operational leadership roles in construction, physician contracting, facility management, information services, and human resources. These two know everything there is to know about healthcare. I know next to nothing, so Lord help me because I'm asking the questions. We will start with healthcare staffing. So this will be for Jennifer, and then we'll go back and forth. Healthcare staffing has been in the news these past several years, where known demographic impact of the baby boomer generation transitioning to retirement may have accelerated by the experience of COVID. Could you share your experience with staffing? Has it only been nurses, also doctors and support? And what actions do you think are needed to be able to improve staffing levels in the future? Jennifer.
Sure. Is this on?
It is. You got to hold it real close.
I'll hold it really close. Okay. Well, first off, I want to say thank you for the invitation here. I was speaking with Alex just a few minutes ago. I don't know why I was invited to this, because I'm an operator by background, and all of you are in the finance field controlling the money, and I like to spend the money. But going back to your first question, so like all industries right now, in the lower 48 and here in Alaska, we're all struggling with staffing. And it's just not nurses. I know a lot of the media is talking about nurses in healthcare and what that struggle it is. It is every position in the hospital. We are having challenges finding that. And not only, the impact of COVID, is an additional impact. So you mentioned the baby boomers, but really COVID had an impact, the cost of living, and then the Alaska factor. So for those of you in the room, and I think there's some online from Oregon and Washington, there is an Alaska factor up here of recruiting people and retaining people in the state of Alaska. We saw a lot of people throughout COVID that retired early. And just have left the healthcare field from the hospital, whether that be just to truly retire or they needed to move closer to family in the lower 48 because of the online schooling was a big factor for us. That's one of the majority of the reasons. And then, just thinking outside the box is how do we recruit and retain staff here in Alaska is very challenging. And, there's going to, with the Muni funds here in Anchorage, we have put in a request, all the hospitals here in our community put in a request to do a healthcare campaign here in the state of Alaska. So I'm hoping that gets approved through the assembly here just in Anchorage. But there's a need for the entire state, and we've got to think outside of the box. And what does that look like? And at the last Hospital Association meeting, a couple of my colleagues were sitting around the table during the network session and just thinking of what we could do in the state of Alaska. Is there an opportunity to share staff? Because a lot of times, my good friend Ross over here, we bounce staff back and forth. They go work at Prov, they come work at Alaska Regional, we just bounce them back and forth. And how do we find ways to look outside of that box and share staffing? Is there an opportunity in the state where we do share staffing and it's a financially stable model for all of us? But also we need to increase the education capacities in this state of Alaska. For nursing schools specifically, every one nurse that gets accepted through charter nursing or the University of Alaska, 2 are turned away. And for those of us that live in Alaska, when our children leave the state of Alaska for schooling, we know they typically don't come back to Alaska. They stay in the lower 48. So we really need to look at the capacity of our healthcare education opportunities in the state to retain young children here in the state of Alaska. And that just doesn't go for nursing, that goes for other fields, therapies, pharmacy, lab professionals, so that goes for all healthcare professions.
That's great. Thank you so much. Ross, hospitals are the main provider of acute care to our community. It is a common experience that these patients have a need for post-acute care following their initial treatment. It may not be widely known that the current community capacity for post-acute care is constrained. Can you share with us your views on community capacity and suggestions for how we could increase capacity?
I know you're using mics.
We're using mic for the online. So if you, it should be.
I hate these things. Yeah. So first off, Jen, very good. I was going to say you can answer them all because you did. You answered that one perfect. I'm going tick, tick, tick. You ticked off everything I was going to tick off right there. So post-acute, I think that's an issue that all of the acute care facilities, not only in Anchorage but the rest of the state, face. And one of the problems is there's a number of limited skilled nursing facilities in this community. We typically at PAMC will see patient days in the 40, 60 to 100 days while we're waiting to try and find some post-acute care. And it's a number of different factors. It's one, being able to find the right setting for the right patient at the right time. A lot of our patients have substance abuse issues, have behavioral health issues, and when we're trying to place them in an assisted living facility, they're not equipped to handle that. So we find that we have to partner with assisted living facilities and send our social workers there, send our behavioral health people there to help them understand how to cope with these individuals. And we're always looking at ways to try and partner with the post-acute care world to get our patients out of the hospital into the appropriate setting. Because it's really not the place you want to be any longer than you have to be there. It's the most expensive setting in the community for that patient. We're working with the city and the state, because one of the other issues is Medicaid itself and getting people qualified to move into a post-acute care facility and making sure that they've got all of those boxes checked. And if they don't, whether it be an assisted living or skilled nursing, they don't want to take that patient. And unfortunately, when they're in the hospital's stuck with them. I call it the hot potato where I live. We're stuck with the hot potato because everybody else can say, no, we don't want that one, and they can be very picky. So it's in the facility's best interest to develop partners and to work with those partners to find the appropriate setting. And we've gone as far as contracting with agencies for beds and saying, I will take 20 of your beds, I will buy them for the entire year. You have to take my patients when they're ready to come to you. If I don't have anybody, that's fine. I'm still going to pay for that bed. But finding the appropriate place for patients is probably our number one challenge at PAMC. Our regional CEO likes to say we have a 100-bed hospital hidden within our hospital. Because of the length of stay issues, we're 1.56 over the O to E for the geometric mean on CMS. We're the highest in our system. We're running right now about 7.2 days on an average patient. So it is our number one challenge that we have to solve.
Yeah, and then I would just add for regional, from a statistical perspective, compared to Providence, Providence is much larger. And so he said he has 100 patients that are sitting there that don't require or don't meet criteria for inpatient care. We have an average daily census of 140, and 40 of those patients don't meet criteria. And I think the hardest thing, we also not only have to partner with post-acute, but we also have to partner with the state. Guardianship in the state of Alaska takes sometimes months to acquire, and so those patients are sitting in beds. Also, funding for those patients could take some time, and then we also have to make sure that it's a safe discharge. So right now, currently in regional, we have 12 IV drug users that are sitting in our hospital, that it's not safe for them to go back out into the community. So they're not really requiring medical care at a hospital level, but because it's safe for them not to re-enter the community, I've got to keep them sitting in a hospital bed. So we have a lot of challenges here.
And that particular patients that, and we have our here also, can sit with you for anywhere for 2 to 6 weeks.
Correct.
While they're undergoing their therapy.
Correct.
And there's no reimbursement on that. So yeah, it is a huge problem.
So follow on to that. If we are capacity constrained, is the solution something that the providers need to come up with, or is it something that the state needs to somehow come up with? I'll start with Ross.
I think the largest player is the state. Whether you're looking at guardianship or you're looking at reimbursement rates. Some of the reimbursement rates haven't been changed in the past 20 years. So I think the state has to step up and own this. Most of these patients are Medicaid patients. They are the state's patients. And getting them in, I mean, it's cheaper it'll be cheaper for the state in the long run. To put them in the appropriate setting. And there's a lot of work going on legislatively right now to make this happen. Okay, so I don't want to make it sound like it's not happening. There's a lot of work going on, but it is difficult to make it happen. But there's a lot of work going on within the state, and they understand this issue, and they're working hard to solve it.
Thank you. Thank you both. Next up, both of your hospitals have done an excellent job of providing high-quality patient care. Starting with Jennifer, could you describe the steps you take to maintain this quality and any opportunities you see that could take this success to an even higher level?
Sure. I think, patient high-quality care is our number one priority in taking care of the patient. And so we've got to focus on that patient. But not only focusing on that patient, we also have to involve the visitor or that family member or that loved one of that patient to be involved in the care to make sure that they're getting that high-quality care that they need. But then beyond that, beyond the patient, you got to have happy staff, and you got to have staff that have all the tools and resources that they need to care for that patient, and really that plays into quality. So what barriers can we remove for our staff? Is it more staff for staff at appropriate staffing levels? Is it the equipment they need, and such? But so also listening to the staff voice, because they usually have solutions and they're on the front lines. So us as the operators and the financials teams, we've got to listen to the front line to see what they need, and then find solutions with that entire team. Plays into the quality of the patient care. And then I think holding each other accountable by sharing those results to the staff level and making sure that they have accountability with each other to make sure that they are meeting high quality care metrics.
And so I would agree 100% with what Jennifer said. And at Providence, Alaska, ours starts with our high reliability program, and everything goes from that point on. But the one partner that we have to work with are the physicians. Alaska, for those of you who don't know, is unique in its relationship with its physicians. Alaska still practices medicine. I should say this, their financial model is still based on the 1980s. We may practice medicine like it's 2022, but our financial model is still a fee-for-service. We've got independent physicians up here who very, very much love that independence. And if we don't work with them and bring them in as a partner from the beginning, then they can disrupt the entire cart. And we've seen that happen over the years as various things have been tried.
And so following on that, because this was raised earlier with some of Sophia's work on value-based care, and if the structure in Alaska is different than it is in the lower 48, what is our path to improving that, changing that, bringing it into the modern era?
I'd look to Sophia first, okay? I think what's going to happen in Alaska is I think we're going to go through a step. And we're in the first step right now. The physicians are expecting us to make us, the acute care facility, to make them whole. Okay, we're willing to play along with you as long as you provide us with an income guarantee and various other financial mechanisms to make sure that they remain whole. And then as the state continues to change its reimbursement model, as the gets a little bit tighter and squeeze gets a little bit more, the physicians are going to start to do what they had done in the lower 48, and you'll start to see that model emerge here. But the very first stage we're in now, they're all with us, but they expect us to make them whole.
And I would agree with that, not only from an income guarantee, but call pay, I think, is brand new to us in the state of Alaska, where it was probably implemented, 10, 15 years ago in the lower 48, and every specialty is knocking on our doors. So I think that is one change that we're seeing. I think there's very little physician employment in the state of Alaska. I don't see that anytime soon changing, but that could change soon if the reimbursement structure eventually changes. And I think one other big thing is clinically integrated networks. I think that's a step that we're going to see to change. I know Prov is starting one. I know there's physicians that are starting one in our community as well, and those are just in the development stages. But it'll be interesting to see where that goes in our communities.
We are changing, and you're absolutely right. I agree. The having employed physicians will be key in the future. But what we've seen in the past, and in the recent past, is if you're dealing with subspecialties, they rely on referrals. And again, it's a very tight community because the physician community protects itself. And when we've tried to go the employed physician route for specialty, we've had little success in that person being able to get the referrals they need to be able to maintain the skills and for them to be happy in their employment. And we've actually terminated those contracts because the physicians weren't happy. So again, it's a partnership. The physicians have to understand that we're not there to take anything away from them. We're there the same reason they are, to provide for the community and to provide the health care for the community at an affordable price.
Thank you. Shifting gears a bit, so healthcare providers, both Alaska Regional and Providence, through the provision of your services, have helped the ongoing trend of extending lifespan for all of us. The result has been a change in the demographic distribution, especially here in Alaska. There are many more people over the age of 60 than in decades prior. Have you seen a change in the type and quantity of the service you provide due to this increase, and what opportunities does this present your hospital? We'll start again with Ross.
I'm thinking about the question. Our Medicare population has grown a little bit, but over the past 8 years I've been with Providence, it's remained fairly flat, probably in the low 30s, 31, 32, goes up and down a little bit. What I've seen more is the need for cardiothoracic surgery, neurology, and some of the specialties that go along with it. But as far as a payer mix, it really hasn't changed an awful lot. Our biggest shift in payer mix has been along the lines with Medicaid, and that was all a result of the Affordable Care Act, and it came in.
Jennifer?
And I would agree. We're seeing the same thing. I think one thing that we are seeing is not on the inpatient side, but on the outpatient side, access to primary care for those seniors 65 and above is very difficult here in our community. We have a senior health clinic it was 65 and above. We dropped it down to 55 and above so that when you are aging, you can find a provider and have that continuity of care. But I have a wait list that's 4 months out for that senior health clinic. And so it is difficult for that transition of care to a provider that sees Medicare patients on the outpatient side for primary care.
Thanks. In a similar vein, it has been reported that access to medical care has not always been as equitable as we would hope. Could you share your perspective? Are these reports accurate? Are there opportunities for your hospital to increase access to health care? And we'll start with Jennifer.
Sure. I think the first one, goes back to the last question, is that senior population. It's a population that there are challenges with, and so that I think there are challenges through many different populations in our state, and there are opportunities for us to provide that access.
I agree 100%. And one of the things at Providence we've done as a region is our community health program, realizing that there are patients out in the community, even in Anchorage, who are in their communities, who are in their neighborhoods, who don't know how to seek health care. So they don't present. I mean, if you present at the hospital, you're going to be taken care of. But the problem is knowing when and how to present. So by having a community health program where you're sending health workers out into the community and you're using members of the community to talk with their community about these services, it opens it up, and it opens up that venue for them to be able to seek the services they need.
Great. Alaska is a very large state with small populations at great distances to your hospitals. Even before COVID, there was use of telehealth to provide services to remote populations. Could you describe how you were able to provide services to remote patients both before and during COVID, and do the recent changes in state law in the form of House Bill 265 provide any additional opportunities?
So I'm going to jump in real quick because when I was in the Army I was up at Fort Wainwright. I was the CFO at the hospital. Senator Ted Stevens had earmarked funds for what he called AFCAN project. It was the Alaska Federal Access Healthcare Network. And there was a $3 or $4 million a year appropriation that came into the state for telehealth back in 2000. And that was so that it could be placed throughout the state in all of the rural villages, so that each health aide had a base with certain instrumentation. Typically, it was just a scope for the ear, blood pressure, a camera, but that was the forerunner. In Alaska was at the very, very beginning of that back in 2000, and we've done nothing but continue to expand upon it. COVID made it happen a little quicker, but we've had a strong telehealth program for many, many years, thanks to that federal program that Stevens had brought to us.
Mm-hmm. And I would just add, it is a way for access to care in our state. However, before COVID, there were specific protections on telehealth. And really, it's about, we don't want physicians from the lower 48 picking and choosing which patients they're going to see in the state of Alaska through telehealth. So before the bill 265, it was really about protections and how do we protect our physicians and that physician-patient relationship in the state. And now with Bill 265, it really is about establishing a relationship with a patient first before a telemedicine visit. And so I actually think it is a good thing, and it will continue to protect our healthcare communities here while providing access as well.
Great, thank you. In a similar vein, provision of healthcare services has been improved over the years with the thoughtful application of technology. Could you describe the most interesting ways you use technology to improve patient experience, comment on the opportunities you see to further impact that technology could have on your operations as well as patient experience? And we'll start with Jennifer.
Are there physicians in the room?
There are not, so
okay.
We can talk all we want. There might be some online lurking.
Maybe online, listening. Well, first off, robotics is really big right now in healthcare, and especially in the state of Alaska, and every physician wants a different robot. And so as a facility, we have to be very careful and not get every single robot, and because we don't have storage space, and will we really get the volume needed to support that robot if we have multiple robots? And so I think while technology is good, robots right now is a big topic here in Anchorage and surrounding communities. I think one of the key items that we have right now that we just started is called the AVAIL system. And the AVAIL system is for physicians, specifically physicians in the operating room or the cath lab are usually supported by a vendor for their vendor product. And typically that vendor flies into the state of Alaska to support that physician. That vendor could be a tech from a cath lab perspective. It could be another physician. And while we all know that travel is difficult, and it was difficult during COVID, and is still difficult, with getting to the state of Alaska with canceled flights, et cetera, the AVAIL system is a telemedicine system for physicians in those procedural spaces where they have that support on a live camera, and that it uses high technology where all the monitors can be seen, the patient can be seen. So that is one of what I'm most proud of, instead of all the different robots I'm now evaluating. But that actually not only is a physician satisfier, it's also a patient safety thing that we've brought to the state of Alaska.
So when they don't get the robot from Jen, then they come over and ask me if I'll buy the robot for them.
And then they go to the surgery center.
And then they go to the surgery centers. But but in addition to the robots, I agree 100%. I think one of the things that the state has been able to do is it has been able to continue to keep pace with trends and with technology that any other medical facility in the country would see. And that's everything from a TAVR to Impellas to a MitraClip. All of these things have come to Alaska, and the procedures are being performed in ways that are the quality is every bit as good, if not better, than you'd find in the lower 48. So we continue to see all of those innovations as well.
I guess I would ask, we've talked about a lot of things, but are there any opportunities that you see that I haven't asked that you might want to talk about? And we'll ask Jen first. We'll ask Ross first.
Opportunities.
Yes.
Okay. So I'm a finance guy by training, so I tend to be more pessimistic. I tend to go to troubles. We have to figure out our staffing crisis in the state. That is our number one issue, and if we can't figure it out, we're going to be in serious issue in the next couple of years. Jen's right. We need to work together. I mean, we're in Alaska. I think we're both I think of it as we're both hunting the same piece of land, and we've got to come to an agreement that, if you go out hunting with your buddies in Alaska, if somebody's successful, okay, everybody's successful. And we have to have that kind of mentality. We have to work together to develop this workforce. And I'm convinced that there are plenty of people out in the lower 48 and within the state that want to come to Alaska. They just don't know they want to come to Alaska because they don't know what Alaska has to offer. And once we can present that to them, there's no doubt in my mind they'll want to come and they'll want to stay because it's a fantastic place to be.
Jennifer?
And I agree. That's the number one opportunity. I think some of the other opportunities that I listed down were access to care, which I think we've already spoken about, preventative medicine, and make sure that patients, Ross said it, they're seeking health care at the appropriate location. And so really, how do we provide that community education to make sure that they are selecting it? And then from a service line, I think for the state of Alaska, one of the biggest service lines that we're missing here is burn care. While ANMC does have a burn program that's only for beneficiaries, and there are a lot of burns that we ship out of the state. And I think, is there a way that we can come up with a burn program?
Great. Are there any questions from the audience that you'd like to pose to our panelists? Or are there any online? Adam? None online. Any from the audience? This is your one chance to ask the boss for a raise.
That's him. I don't want to check.
Go ahead, Sophia.
I think one of the, oh, sorry.
Oh,
Somebody have a question?
Sophia raised her hand.
Coming from the value-based care perspective, a lot of success in value-based care is determined by provider and payer ability to exchange data. So I wonder, and when I heard the question about opportunities, that's where my mind went. We have a huge opportunity to improve how we share data between providers, between plans and providers, between the state and providers, to reduce waste, to reduce duplication of services, so that if a patient seeks preventive care over at Alaska Regional on one of your clinics, that we have an opportunity to know that, so that we don't duplicate services. So I'm wondering if you have any comments on the work on a future of data exchange, something maybe you have underway already for your facilities, and maybe you work with the state or maybe with plans.
I think you make a good point. My mind goes there as well. I think, regional Providence, we do a great job because we're both on the Epic system. And so for when patients come in, I think specifically of patient safety around opioid use. And so when patients come in, we can see Providence record, and you guys can see ours as well. But I think there's a much larger data sharing opportunity that we can have with payers. And I know, I'm not prepared to talk about it today, but I know Healthy Connect, they were working with getting a data, but I think they have had some change in their leadership just recently, so I don't know where they are in the process, but I agree it's a big opportunity for our state. I was originally from Florida with my HCA career, and we reported all of our data to ACA in the state, and there was a state database, and payers could have access to it, primary care could have access to it, specialists, and not only from a patient care perspective, but also a cost perspective, a service line perspective. You could track and trend where service lines were needed in the state of Florida. So there are states out there in the lower 48 that do it well in sharing data. So I would reach out to Healthy Connect or the Hospital Association to get a better answer for you. I'm just not well versed in that.
Any other questions? See, there we go. Now she's going to ask for the raise.
Come on, Becky. Yeah, she's fine.
I was on mute. Just with everything that you guys have talked about today, understanding that we're the finance people kind of supporting and behind, whether it's the switch to the payment structures in finance, whether or staffing, what do you look to us, I guess? What's the number one thing that you turn around and you're like, I need this support, I need this information? I guess just would love to hear both of your perspectives when you're kind of turning around, and how do we support you through these things, or what else would you need or look for?
So the first thing I look for is a questioning attitude, looking at it and saying, trying to understand the why and the end goal, whatever the metrics may be, being that set of eyes at the table who is we do a lot at Providence. We have a red ball and a blue ball. The red ball is the antagonist, the blue ball is the protagonist, and you get assigned a ball at a meeting, and that's your job, whether you agree 100% with the proposal or not. You to be that person who comes in with that set of eyes, who looks at it. I mean, because I'm not sure about Jen, but I will tell you that Providence still expects the same margins that they saw 5 years ago, and it's not there. Okay, it is not there, but they still expect it. So the finance side of the house is put under a lot of pressure. And when we come up with ideas and operators want to do something, they want to do something that's best for the patient. And I really have the philosophy, if we do what's best for the patient, the finances will follow. I really believe that. But sometimes we need that set of eyes looking at it going, what does this really mean? And asking those probing questions. What is your payer mix going to be? What are you actually thinking? Is this real money, or is this funny money? Is it just going to save by getting by not bringing any new revenue into the house? A lot of times I have people saying, well, I can do this and it'll cut a day, or I can do this and we can charge for this on the inpatient bill. Well, great, we're just charging more, but we get reimbursed by a DRG. So having those questions, because the operators don't understand that. Okay, the operators are on the mentality, I get paid for everything I do to a person. And that's not really how the reimbursement works. So helping them understand that reimbursement model as you're at those tables is extremely important.
And I definitely would agree with that. I don't have a CFO right now at the time, and I actually don't have a finance team at the time either. I have a senior accountant that's brand new. She's been in her role less than 6 months, and so I've had to take on the CFO role. And from an operating perspective, I want it now, and I want it quickly. And filling in as the CFO and the finance team the last 3 months has really opened my eyes of what you do to get those answers to me. And sometimes it's not quickly. But I definitely agree, coming to the table with what's the why, questions, and also just looking at the whole picture. And I absolutely agree that if we take care of the patient, if we do what's best for the patient, the finances will follow.
And Becky, I'll say on the back side of that is understanding the operations, understanding what the operator's looking at, and understanding what the operator's trying to do. Because they want to do what's best for their patients, okay? And because something may not pan out economically, okay, doesn't mean there's not another way to skin that cat so that they can. So again, trying to understand what it is and what's driving them to want to make a change. Why do you need 10 extra FTEs to do the same thing you've been doing for the past 10 years with the same number of FTEs? What are you trying to do? And by understanding that, you can understand where they're coming from, and you can help them come up with a reasonable answer, because a lot of times it is about coming to a consensus.
Other questions?
I have another question, if I may.
What?
And this is not intended to be a trick question, but if you're able to answer it. So, healthcare regulatory landscape is very complex, right? In Alaska, there are a number of rules and regulations that are very, very unique to Alaska, from the way the Certificate of Need program is structured, the statute and the standards and the regulations, to what is referred to as the 80th percentile rule. So there are regulations in Alaska that are very unique to Alaska. And I wonder so my question is, what changes in the regulatory landscape in Alaska are you anticipating to see maybe in the next 5 years, or what changes would you like to see?
So from the acute care side, we're starting to see some of those changes now. So for those of you who don't know, as of today, we get reimbursed on a per diem basis for an inpatient. It's not a MSDRG basis. The state is moving to a new model where they're going to start that reimbursement methodology for an acute care facility. The 80% rule primarily pertains to providers. Okay, so I would look to our physician, enterprise person to give a little bit better answer on that. But the state is starting to change its reimbursement methodology for inpatient, because they've realized that this is not the best way to go down, and we're starting to look more and more like our counterparts in the lower 48. I think there's only one other state, I can't remember at the top of my head right now, but I believe there's only one other state in the nation that reimburses on a per diem methodology.
Any other questions? Hearing and seeing none, I want to thank you both for taking the time, providing the perspective from senior leadership. It's been very helpful, and we have a very small token of our appreciation, and thank you very much.